When I look at patients who come to me with shoulder pain, I have some kind of non-negotiables that I think are important. And of course, all this is underpinned by my education. And I believe my symptom modification is part of my education and challenging negative beliefs. So educating through movement, not just through our words and what we say to patients. But in terms of what I actually do in my head, they've come to help with pain. So I want to look at things that are going to help potentially modify their pain. Exercise is always central to what I do and will be based on their symptom modification if I'm able to change it. But in my head, what I'm trying to achieve is make life easier for the shoulder. So unload it, if you like, to get some sound foundations, and then reload it to make sure they've got the functional capacity to do what they need to do. So I kind of, as part of my assessment, I look at symptom modification, but I also use a test where I assess the assess the arm in prone and look at their passive rotation and then their ability to do that actively. And most patients with shoulder pain won't be able to do that, but if you support the weight of the arm, they can do it. And I think this through range and this rotation reflect what we currently understand about the cuff, the scapula, and the muscle function around the shoulder. And they're simple, objective things I can retest to assess the value of my exercises. So generally, they'll do something through range, something to target that rotational role of the cuff, generally with the arm supported. But then how I progress will be very dependent on what the patient wants to get back to.